Hello, good morning. I know it's been a rough week and there are so many moving parts here, which means that there probably are even more moving parts for you guys. But thanks for hanging in there. And of course, we remain to be flexible, when certain things happen or if there's some kind of glitch in the system. But we're going to talk about antepartum and some adaptations to pregnancy. Um, I'm going to, as I talk to you about these things, especially the first several slides, you will note that this kind of gives you a background of how different the pregnant woman can be. And that I think there was one person at some point in history that said that the pregnant woman is so different that she could actually make up a third sex. And when we start to look at all of the changes that happens in the woman's body, you'll see what I mean. All right, so we're going to look at the uterus first, which is one of the most obvious organs to look at because it has the most to do with the baby. So before conception, it looks kind of like an upside down pear. So you can imagine there's the pear like this. And remember, I showed you the balloon in the last video, and so you can kind of imagine or get an idea of what it looks like. There is a predictable growth. So we expect the uterus to grow at a rate that we can pretty much assume that it's going to grow at. So at the during the end of the or by the end of the first trimester, it should be midway between the symphysis pubis, or that bony little part down low, and the umbilicus, your belly button. In trimester 2, it's going to end up midway between the umbilicus and the xiphoid process. And finally, at term, it's going to be all the way up at the xiphoid process, which means it's going to be difficult for mom to get a deep breath, and that's why she kind of gets out of breath. This growth that happens during the trimesters goes along with estimating the delivery date. Now, is it always the same? Is it always right? Are there any variations? Of course there are. But basically, this is what you're going to be looking for. You'll need to know how to do this. The estimated date of delivery, they call it Nagel's rule. And it's where you take the first day of your last normal menstrual period, you subtract 3 months, and you add 7 days, and that will be your due date, or not your due date, but the patient's due date. So if today I'm recording this on the 19th, so if I go back 3 months, this is March 19th, so it would be February 19th, January 19th, and December 19th, all right, and you add 7 days, ooh, that would be December 26th. That's right around my birthday. Anyway, that would be the due date. So make sure that you know how to figure a due date, because you're likely to see that information again. So some other uterine changes that will occur is that the contractions will continue throughout pregnancy. They're not, I don't want to say that they're fake, but they're not real contractions like the contractions in labor, because if you recall, true contractions cause effacement and dilation. So they call these Braxton-Hicks contractions, or I've also heard them termed as practice contractions, but they're definitely not real labor. They're considered false labor. As far as uterine blood flow goes, the blood flow rises dramatically because, of course, you've got this little baby that needs oxygen and nutrition, and that's the way that they get it, is by the blood flow through the placenta and then onto the baby. So it's very important for the purpose of oxygenation and nutrition, but it's also important for the process of waste removal. So you've got a whole lot of things, and as we go on, you'll see just how much the cardiovascular system does change. The cervix, of course, this is that on the balloon. It's the part where you blow into it. is hyperemia. In other words, hyper meaning a lot, emia meaning blood. So there's a lot of blood. There, when I say blood, not actual blood that you can see, but the tissue is congested. And so it's going to make it look bluish. And they call this the Chadwick sign. So if a woman is getting a vaginal exam and you do see the bluish tinge to the cervix, then it is a sign that that the woman is pregnant. There's also changes in consistency in terms of the cervix. If it's before pregnancy occurs, it's like the tip of the nose. After conception, it becomes more like your earlobe, so it's kind of soft and squishy. And then at the beginning of labor, it should be kind of like a butter, especially butter, not a butter. But it should be almost like butter where it really moves around very, very easily. And of course, again, that depends upon the strength of the contractions. The mucus plug is that bloody show, and I think I mentioned to you that that is constantly changing throughout the pregnancy. So it's not the same old mucus plug throughout the whole 9 months, but it does block the ascent of bacteria up into the uterus. So it does have a real purpose. The vagina and vulva, again, there's increased vascularity there. The vagina is acidic. A lot of times that prevents some bacterial growth. But there's also some little extra sugar in there, so it can increase the incidence of a yeast infection. So we're just got a whole lot of fun things to talk about. As far as the ovaries go, the major function was progesterone. When the placenta develops, it takes over that progesterone production. And it is high levels of progesterone and estrogen that suppress LH and FSH. LH being luteinizing hormone and the FSH follicle stimulating hormone. And both of these hormones are needed for the growth of the egg follicle and its rupture from the ovary so that it can move down the fallopian tube and possibly be fertilized. Of course, that also stops menstruation. The breasts also change. So you're kind of getting an idea. This whole pregnant woman is changing all over the place. But the glandular tissue in the breast begin to develop. They're called lobules, and these lobules start to grow and enlarge from about 4 to 6 weeks of pregnancy. And if you've ever been pregnant, you know that one of the first things that you notice may be some breast tenderness, and that's because changes in the breast are taking place. Usually, the woman can create mature breast milk or when she's about 16 to 24 weeks of pregnancy. Now, pretty much a baby is not going to be able to survive at 16 weeks, but at 24 weeks, you're pretty good to believe that milk production will be available should the mother decide to breastfeed. Montgomery glands are those little bumps on the areola, and those little bumps produce a lubrication, and this helps to keep the nipples and the areola nice and moist, because as the baby sucks, of course, it can cause that area to dry out and become irritated. I think this is interesting. The cardiovascular system, the heart enlarges because of the workload. It will go back to normal, but it does enlarge a little bit. It can shift upward and outward. Heart sounds may sound abnormal with a third heart sound, but and also with a murmur possibly, but that's all normal. That's not unusual to hear in a pregnant woman. So don't jump to conclusions, because there are a few that we could jump to. The pregnant woman is quite an odd person. On with the cardiovascular system. Look at this. Total blood volume increases by 45%. So what's nice there is that remember we said that the woman can tolerate a good amount of blood loss during labor and delivery, and that 500 milliliters really isn't a whole lot. And if she loses a little bit more, we said up to 2 liters of fluid, in all honesty, that won't be a lot for the woman to lose because her blood volume has increased that much. Her red blood cells increase in mass and their iron binding power, which is a good thing because that means more oxygen. The white blood cells increase during pregnancy. Platelets decrease slightly, but it's still normal, so we're okay there. And plasma increases, and that, of course, has a whole lot to do with the blood volume. But going back to the white blood cells, as a nurse and you're looking at these different lab values, we have to be careful to understand that these lab values will be a little bit different during pregnancy and not jump to any conclusions. So let's look at anemia. In the first or third trimesters, true anemia means that the hemoglobin will be less than 11, the hematocrit less than 33. Now we're talking about less than. In the second trimester, okay, so you've got the first and third, but in the middle, true anemia is going to be less than 10.5 and less than hematocrit less than 32%. All right, when I talk about true anemia, there's also something called, and I can't remember if I've actually mentioned it, but pseudoanemia. And with pseudoanemia, it looks as though the woman has anemia, but because she's pregnant, she really does not. Cardiac output rises up to 50%. It's most efficient when the woman is lying in a lateral position. And please note that ideally, left side is good, but the right side is not bad either. So it kind of depends upon what the comfort level of the woman is. Now, if she is on her right side and is having some difficulties, then, or the baby's having some difficulties, say in labor, then you may want to switch to the left side. So you have to look at the whole patient and not just this particular side. As far as blood pressure goes, there's a decreased vascular resistance, which means that the vessels are not putting as much pressure again on the blood or exerting pressure on the blood that's running through them. So they're kind of more elastic, which allows the blood to move through them a little bit easier, which means the resistance is lessened, and that, of course, lessens the blood pressure. The left lateral position does cause the greatest decrease in blood pressure. So if a woman comes in and she has high blood pressure, one of the first things you would do is put her on her left side. The supine position causes hypotension. There's a decreased cardiac return and output, and it also decreases placental flow. So important blood flow changes. You've got the blood flow to the placenta. The blood of the baby never mixes with the blood of the mom. You've got a maternal side of the placenta and a fetal side of the placenta. So it's like mom's blood runs through the maternal side. I like to call it drops off the oxygen and nutrients. The blood from the baby is running through the maternal side and picks up those oxygen and nutrients. So that's how that works. There's also increased blood flow to the skin, and as a result, this blood loses, because it's close to the surface, it loses some heat and helps to cool mom off. Breasts increase in vascularization, so there's more blood vessels, more blood flow to that area. The uterus puts weight on the inferior vena cava, which obstructs, that's blood, not flood, return. So it can cause some swelling in the ankles. Swelling in the ankles during pregnancy is pretty common. In the past, they've associated that with pregnancy-induced hypertension or toxemia, or, it has so many different names. But they have found that that swelling in the ankles is pretty typical for all pregnant women, so they don't so much associate it with it anymore. Now, if you've got other symptoms, we're going to talk about PIH and DIC at another time. But if you do have some other symptoms, then you kind of pay more attention to that swelling. The respiratory system, oxygen consumption increases because you've got the baby on board as well. Um, we've talked about hyperventilation, the GI system, progesterone slows down everything. So including that gastric sphincter. So in other words, you eat something and the gastric sphincter isn't quite as tight as it once was because of progesterone. And sometimes that will cause heartburn. Also, the small and large intestines slow down, so that can cause constipation. So, all of these symptoms that a mom has during pregnancy, there really is a very logical reason for them to occur. There's increased blood flow through the kidneys, so there's going to be more urine. And then you've got the uterus, as it enlarges, it's going to put more and more pressure on the bladder. And so it's going to cause mom to want to go to the bathroom a whole lot more. Now, one of the things that you will see when a person has, or when a mom has pregnancy-induced hypertension, is some protein in the urine. However, if you've got a trace of protein in the urine, it is not necessarily pathological, or it doesn't necessarily have to do with pregnancy-induced hypertension. So again, guys, you don't take any one symptom and make a diagnosis. You have to look at the whole person and see, how do these things work together? It's like being a detective and really looking at all of the different pieces and say, well, this one fits, but this one doesn't. So, be aware of that as you are assessing your patients. There can be some hyperpigmentation, melasma, which is that mask-like look, kind of darkened. Linea nigra, which is a black line that runs straight down the middle of the abdomen, and then stretch marks. And usually you don't see the stretch marks until after delivery, but sometimes you may see them in the abdomen or on the abdomen during the pregnancy. Calcium storage and absorption is increased for the baby. Pelvic ligaments often soften, and as they do, sometimes they'll stretch, and you'll feel the mother will feel kind of like a sharp pain. And of course, this can be really scary, but typically that sharp pain is normal, and it's nothing to be worried about. The joints relax, and remember when I was talking about in the last lecture that when the joints were in the scalp, there are different bones that make up the scalp. There are different bones that make up the pelvis. Well, it is that it's that relaxin or progesterone that softens those joints. So not only in the scalp and in the pelvis, but in all joints, and it kind of causes lordosis. And lordosis is when the shoulders go back. I kind of like to think of it as the Lord of the house is coming. So very proud. Whereas with the other way, I can't remember what the name of it is. Kyphosis, where you kind of hunched over. Also, you can have a diastasis recti, and that's when the rectus abdominis, which is the muscle that runs up and down in the abdomen, can separate just because of the pressure against that muscle. Okay, so very quickly, we won't spend a lot of time on this endocrine system. We already know about the FSH and LH. I will tell you that the pituitary gland also secretes prolactin, which plays a part in milk production. Oxytocin actually plays a part in the contractions of those lobules, or those little tiny alveoli, which causes milk ejection. Now, what what actually stimulates that is the baby sucking at the breast. So the more the baby sucks, the more milk is going to be used or produced. The thyroid gland enlarges, and there's an increase in thyroxine. The parathyroid hormone fluctuates in response to any calcium needs that might be there. Pancreas, the glucose levels lower. Insulin sensitivity, glucose levels rise in the event that there is a fetal need for it. And then sometimes inadequate insulin leads to gestational diabetes. Interestingly enough, we don't really cover gestational diabetes in this course. It's not an exemplar. Not sure why, because it's important to look at. Um, Maybe I'll stick it in some place where I can, since we've got all of this free time, to put other interesting things into the course. Right, just kidding. Some placental hormones. Isn't it amazing that just one little thing that looks like I think like a liver, big old liver, raw liver, can do so much. But look, it makes HCG, that human chorionic gonadotropin, and then it produces progesterone and estrogen until the placenta can do so. That's the corpus luteum. I'm sorry, and that's just like a little tiny glob of something that is in the uterus until the placenta forms and attaches to the wall. Estrogen stimulates uterine growth, it increases the blood supply, it aids in the ductal system in the breasts, and of course, it has something to do with that hyperpigmentation. Not sure exactly how that works. So I hope you don't have that question, because I won't be able to answer it without looking into the evidence-based information. Progesterone is also produced. It maintains that endometrial layer, and that is important because it also kind of keeps it calm, the uterus calm, so that you aren't getting contractions too early. It prevents spontaneous abortion and tissue rejection. It relaxes the smooth muscle. Relaxing kind of goes hand in hand with it. It inhibits uterine activity, softens connective tissue, and it helps to lengthen those pubic ligaments that may, when they stretch, and you have that sharp pain that I mentioned before, that's partly responsible for it, that relaxing. All right, this is so difficult and to explain, because sometimes you will have these symptoms overlap a little bit. So we're going to talk about presumptive indications, but we're also going to, I'm going to talk about a couple that overlap with one another. So presumptive, that means I presume that I'm pregnant. You're not sure, you have no proof, all right, but you have some symptoms. So these are not absolutes in terms of confirming a pregnancy. So you have the absence of menstruation. Well, that is certainly part of how a pregnancy could be confirmed, but you may have an absence of menstruation for another reason. Nausea and vomiting. Yes, that is a symptom, but you could have the flu. Fatigue. You worked a really long week. Urinary frequency. You might have a UTI. Breast and skin changes. It could be some pathological problem. It could just be a normal response to getting ready to start your period. Vaginal and cervical color changes. Again, okay, but you're not going to say, oh, gee, the cervix looks blue, you must be pregnant. You know what I'm saying? And then fetal movement, of course, that can be assumed. You feel something in your abdomen. Maybe it's gas. So these are presumptive signs and should not be, these should not be considered to absolutely confirm pregnancy. Now, here are some probable indications. In other words, these go a little bit further and are more likely to indicate pregnancy. So that would include abdominal enlargement. Okay, yeah, the baby's growing, your abdomen's going to get bigger. Cervical softening, ballotment, which means that when you go up and you touch the baby's head, you're going to and push it away, it's going to come back. Um, uh, Palpation of the fetal outline, in other words, from the outside, you can actually lay your hands on a mom's abdomen and feel the outline of the baby. Uterine souffle, you push the against the uterus, and it kind of like a wave comes back. And then of course positive pregnancy tests. Now all of these could or could not be, but more likely. All right, a positive pregnancy test is not always accurate. Most of the time it is, but it's not always. I think they've gotten so much better that if a pregnancy test does come back positive, you know, that you buy at the drugstore, it's probably a pretty good sign that it is a positive confirmation. But if you really want to make sure this woman is pregnant, you can hear the fetal heart sounds. You can see the fetal movement, or it's felt by an examiner, and you can visualize the fetus. You do an ultrasound, and you know, lo and behold, there's a baby in there. So this is one of those Nagel rule questions. I do like to include NCLEX questions in my PowerPoints most of the time. Sometimes I just forget to put them there, but in this case, I put it there and also giving you the answer. So a 22-year-old tells a clinic nurse that her last menstrual period was 3 months ago, which began on 11/21. She has a positive urine pregnancy test. Using Nagel's, which date should the nurse calculate to be the woman's estimated date of delivery? And here it's 8/28. Didn't have to think very much. Also keep in mind that if you get pregnant in 1 year, listen to me, if you get pregnant in 1 year and you are required to give the date in terms of the month, the day, and the year, it may, like if you got pregnant in September, it's not going to, of 2020, the due date will be, you know, in 2021. So I don't think I have a question like that to give you. I hope I don't, but you may see it on another test, and be aware that, you know, the years change and that the due date may actually be the next year. A nurse is in the room during a physician's examination of a client who thinks that she may be pregnant. Which finding during the examination supports a possibility of pregnancy? Increased hyperplasia and hypertrophy of the breasts. Okay, vaginal atrophy, that wouldn't support pregnancy. Decrease in respiratory tidal volume, it would be increased. And then an increase in hemoglobin, again, that decreases. Not bad, but it does decrease. So on that initial visit, there's going to be a obstetric history. Guys, know what the GTPAL, gravida, is the number of times that a woman is pregnant, including the current pregnancy. So if I was pregnant 4 times in my life and then I was pregnant now, then I would be a gravida 5. Para is the number of pregnancies ending at 20 or more weeks. So if I deliver at 21 weeks, that would be included in that para number. Term, or T, is for term births. That's the number of births that went to the term at 38, 39, 40 weeks. Preterm births are between babies that are born between the 20th and the 38th week. The number of abortions, and let's make it clear that abortion not only includes elective abortions, but spontaneous abortions as well. So, you know, be aware that that word abortion, if you have an aversion to it, means more than just an elective abortion. It also means a miscarriage. And then any living children that the mom may have. Conception, as far as going to see the doctor, conception to 28 weeks is usually every 4 weeks. 29 to 36 weeks every 2 weeks, 37 weeks to birth every week. And they will do all of these activities during those assessments. Leopold's maneuver is simply laying, the provider will lay the hands on the abdomen and uh, determine what position the fetus is in. When you are actually measuring fundal height, and I believe there might be a video someplace about that, the bladder has to be empty, or it will, cause the fundal height to be different from what it actually is. But the tape is stretched from the top of the pubic bone to the top of the fundus, and from about the 16th to the 18th 16th to 18th week until the 36th week, the number of centimeters that you measure is approximately equal to the number of weeks pregnant. So if it's off by a couple of centimeters, it's really no big deal. But let's say it was off by 4 or 5. Do we have twins? What else is going on? So it would just be an indicator of further assessment, not necessarily that there's something wrong. Some discomfort. You've got hyperemesis, which is that nausea and vomiting. Usually it's not going to be bad, but there are some women that with hyperemesis gravidarum that are vomiting so much that they become dehydrated, and it's not a normal morning sickness. Heartburn, backache, round ligament pain, varicosities, constipation, hemorrhoids, and leg cramps. And quite honestly, we've covered all of that when we were going through the changes in the body of a woman during pregnancy. There's some screenings that need to be done. Ultrasound, usually 1 to 2 times. It detects the size and may detect abnormalities, but not always. Glucose screening between 24 and 28 weeks. If there is a problem with the amount of glucose, then the mom may have to do a glucose tolerance test. Isoimmunization, and these are just for women who are Rh negative and the father's Rh positive. So it is important that that be examined. And then the pelvic exam, because they want to be able to feel the cervix, because remember that cervix changes from the tip of the nose to the earlobe. So also you can feel the presenting part. Is it the head? Interestingly enough, the head will feel kind of firm, but a butt will feel like a butt. And sometimes you can actually, especially during labor, your finger may get inserted someplace. Let me just say that. In a multifetal pregnancy, of course, 4 centimeters are greater. The fundal height is 4 centimeters greater than what you might see typically. Older women, African American women, family history, and fertility drugs will all play a part in whether or not a woman will have twins. Physiological adaptations are greater, obviously, because there are so many and more changes. Visits to the doctor are probably going to increase. Monozygotic twins mean that it's from one egg, and that's when you have identical twins. But if there are 2 eggs, you'll have fraternal twins. So 2 completely different looking individuals. This is something that is important, and you actually may see this somewhere on a test, but definitely in a NCLEX exam you will see this. But during that first trimester, there's you're going to be excited, all right, but then you're going to go, oh crap, I'm pregnant, and you're going to kind of focus on yourself and maybe be a little worried. But by the second trimester, you begin to gain some confidence, and the baby is more of the focus, and you become a little bit happier and excited. And then the third trimester, um, all of a sudden you realize, oh no, I'm due in 3 weeks, and I need to get ready for this. And so it's normal to feel those things. Um, I'm probably going to do the maternal role taking in a discussion type board, so I'm not going to go over that right now. Psychosocial adaptations, of course, it all has to do with, how old is this woman? Is she uh, 16 or 14, or is she 49? It's going to make a big difference in terms of how that person approaches the pregnancy. Is there one baby or three? What kind of social support does that mother have? Has her husband just left her? Is she in an abusive relationship? Does she only have her mother? Is she a military wife and there's nobody around to help be a support? How do they have? Does she have the money to support a child? What kind of arrangements does she have? Does she need to make to provide for that baby? And then any other abnormal position or abnormal situation can affect the psychosocial well-being of the mother. Recommended weight gain, usually between 23 and 35 pounds. First semester, it's going to be about 1.1 to 4.4 pounds. And then in the second, that's total. And then in the second and third trimester, about 0.8 to 1 pound per week. So, there's some pretty good growth during that time. Um, and all of these come into play in terms of what influences weight gain. Young people may not gain as much. Their metabolism is higher. Unmarried, um, low income, individuals, oftentimes they get more carbohydrate foods because carbohydrates are cheaper to buy. And it may be that that's all they can afford. Poorly educated mothers may not know that it's important to include fresh fruits and vegetables. Insufficient prenatal care, poor overall health to begin with, and substances that interfere with food intake. Now, let me explain that, because there's something called pica, and pica is when you crave a non-food substance. For instance, uh, not soda, washing detergent. Of course, you would think that's horrible, that's nasty and will kill you. But some women have been known to really crave um, detergent. Others chew on rubber or rocks. I mean, there's a whole bunch of stuff, but look it up. It's really interesting. So if you fill up on stones, that's the only way you'll remember that. You're not going to want to eat. So, carbohydrates, fats, proteins, vitamins, these are all of your normal nutrients, all of that nutrition stuff that we all need to know and that we don't. But carbohydrates are needed for that energy and fiber, fats for the absorption of fat-soluble vitamins, which are your A, D, your A, D, E, and K. Protein for the synthesis of tissues. And if you think about it, you've got a whole new human being growing. So we want to make sure we have plenty of this stuff. Prenatal and water-soluble vitamins. The vitamins must be eaten daily or swallowed daily. Minerals. Usually there's an adequate but added iron may be needed. Coffee binds iron, which means that it's not absorbed. And orange juice can increase iron absorption. Calcium is needed for fetal bone development. And don't worry about eliminating or decreasing salt unless you really are salting things a lot. But just salt to taste, unless you salt so much that it tastes more like salt than it does mashed potatoes, say. Folic acid is should be started actually before pregnancy, but it's really important in the reduction of neural tube defects like spina bifida, anencephaly, cleft lip, and cleft palate, and even some heart defects. So a mom should get at least 400 to 800 micrograms per day. The lactating mother needs 330 to 400 additional calories a day if she is breastfeeding. Um, fats need to be increased and vitamins should be increased. But the non-lactating woman can return to a normal diet. So, and don't encourage, it shouldn't be discouraging to a mother if she has to take those extra 330 to 400 calories per day, because it's really to the benefit of the baby. A nurse is reviewing with a nursing student that lab tests reveal a low folic acid level in the patient. The nurse explains that a low folic acid level is associated with a higher incidence of, did somebody say B? Yes, very good, Logan. And everybody else. It is B, spina bifida. And there you go. All right. This is just, we have to go over the assessment of fetal well-being, and fetal activity should be there. And if there is less than 10 movements in 12 hours, it should be reported. If there's less than 3 movements in 1 hour, it should be reported. Now, does this mean that something is terribly wrong? Probably not. But there are some parameters that you want to follow so that you can follow up on it and make sure that nothing is wrong. An ultrasound can be done transabdominal or transvaginal. With a transabdominal, the Doppler will be placed on the outside of the abdomen, and with transvaginal, there will be a instrument that goes up into the vagina, and the ultrasound will be done that way. And all of these things that are listed here are indications or will diagnose or detect certain things through the use of an ultrasound. A non-stress test is when there is will determine that there's an adequate fetal oxygenation and an intact central nervous system. You can tell after a while that I get tired and my tongue gets twisted. But the fetal heart rate should change with fetal movement. All right. So in other words, if I run around a whole lot, all right, my heart rate's going to increase. If the baby is moving, the heart rate should increase. So that's pretty much what you want to see with that non-stress test. It's a very quick test. It's non-invasive, and it usually takes about 20 minutes. Fetal acoustic and vibroacoustic stimulation is when they use sound and vibration to elicit a response from the fetus. It's non-invasive, the results are rapid, and the time for an NST or the non-stress test is even shorter, or it is shorter than this one. The contraction stress test evaluates the fetal heart rate during a contraction. Prenatal testing, in terms of a biophysical profile, it uses ultrasound and the non-stress test. So the ultrasound will look at fetal breathing, movement of the body and the limbs, flexion of the limbs, extension in fetal limbs, and amniotic fluid can also be visualized. And they will also include NST as part of the biophysical profile in determining how well the baby is doing. And they're not going to do this like all the time, only if there's an indication that maybe, we want to make sure that this particular baby, because of some, maybe a woman didn't get any prenatal care and she's carrying, she seems a little bit smaller than usual. They may want to do it for that. A lot of these things are to rule out problems and also to detect them, but just because there's an extra test being done doesn't mean that it's necessarily a bad thing. An amniocentesis is where they will take a needle and they will penetrate the uterus. It's guided by an ultrasound so they can see exactly where that needle is going, and they will withdraw some of the fluid from the uterus. Now, this can cause a woman to go into labor, um, and it can also cause um, a mixture of blood between the baby and the mom, and this is important if you've got an Rh negative mom, because it can cause a reaction. But they will analyze the amniotic fluid. This is a little more specific and accurate for genetic abnormalities, even for the age, birth weight. I'm sorry, but I'm not sure exactly how they would do that, or determine the birth weight. Assess maturity of the fetal lungs, and now that is important, especially if a physician might anticipate an earlier delivery. They want to make sure that the lungs are mature enough to deliver the baby. Mature baby usually has surfactant that's available, which facilitates breathing, but an immature baby may not have as much surfactant, and they will usually give surfactant to the baby during the pregnancy. We also have chorionic villus sampling. It's done in early pregnancy. Amount of villi obtains a small amount of villi in the placenta. It's a very early diagnosis of birth defects, usually involves a combination of measurements. I'm not real familiar with this testing, but typically it's probably going to be done if there's a genetic issue that might be in question. Nursing responsibilities: always reassure the patient, assist the provider, and clarify the provider's description of the test. So if the doctor has said we're going to do an amniocentesis, and the nurse comes in and says, okay, you're getting an amniocentesis, or do you have any questions? Do you understand what this procedure is? And the mother says, I have absolutely no idea. It is then the doctor's responsibility to come back in and re-explain. Now, the nurse can help to explain or help with understanding, but ultimately the provider is responsible for getting consent.